Good morning, everybody. Uh, First of all, I thank President IMA, Dr. Veena Madam, for having invited me for this probably honorable guest lecture because I am from this place. I had my earlier education, born and brought up here till PUC. Then eventually went on to settle in Mangalore in the district center. I know Dr. Chidanand since childhood. Sir, I know him since childhood. So I know him in different ways because he also MS surgery. We are in the same surgical site. I thank Secretary Ravikant. I thank Soumya, Dr. Soumya. Thank chairpersons, Dr. GK Bhatt, sir. I know him since long time. Satish Bhatt is there, my good friend. Himakar, Dr. Himakar, I know him since long time because he did this MD in KMC Mangalore in Wenlock, so I've been meeting him, and Dr. Sri Krishna and many others. Dr. Vijayalakshmi Madam, I met her today, Madam, very nice of you, and all senior respected consultants, my colleagues, young dear students. Topic today is rather a big topic because in surgical side many times we discuss abdomen trauma for one day CME. So I have to concise it for 20 minutes. That's what Madam has asked for. So within that, I'll discuss blunt injury of the abdomen. So abdomen trauma is a very, very vast subject. Often it is difficult to manage. Often it is missed. That is the most dangerous thing. So what are the different types of abdominal trauma? There are only three types. Grossly look into that. Penetrating trauma. That's what I'm not interested. I was told to talk about something else, but it is quite common. So blunt trauma, this is what I'm going to discuss briefly, or rather highlight for clinicians and in general and students in special. So different, it is easily missed. It is common in rural areas. So that's why it is more important because many times it is life-threatening and it is multi-organ, multi-system injuries can occur. Associated injuries also often missed. And abdominal wall injuries, again, I'm not going to. These are the three categories of abdomen injuries. What we see interested is the central one, blunt trauma, often missed. Now you can see that stab injury there, and you can see here blunt injury, just abrasions are there. He had a hemoperitoneum, we had to explore him. He had a mesenteric tear, he had a aortic injury also. So we had to clamp. So this is something, so many things sometimes missed. If you don't look at these things, last thing, if you miss because you concentrate on other things. And mechanism, all of you know, either crush injury, especially in the RTA, and sharing injuries this is very important because you know that small bowel is very mobile, duodenum is fixed, ileocecal junction is mobile but not as mobile as a small intestine, either jejunum or ileum. So there is a sharing force like between the duodenum and the ileum. So the sharing force causes explosion of the junction and causes the bowel injury, even though there is no external injuries. So that is quite common, that causes peritonitis and eventually sepsis and so on. Penetration, not penetrating trauma from the outside. Many times chest injuries, lower rib fracture occurs, that fractured sharp rib injures during the phases of the inspiration or respiration, injures the spleen, and it is often kept unnoticed and eventually they sanguinate, and unless you intervene, unless you treat with identification, you may lose the patient. So that's why that is very important because it is not the outside penetration. It is a mainly example, rib fracture. And organ which is enlarged as such is more prone, like tropical diseases, malaria, where splenomegaly is quite common. Such enlarged palpable spleens are more prone for blunt injury. And organs or part involved, again, most common abdominal wall, I'm not discussing. Solid organs, spleen, liver, kidney, pancreas. In that, spleen is the commonest one, most common involved, so causes hemoperitoneum, hollow viscous stomach, small, large intestine, urinary bladder, ureter. Mainly urinary bladder injury occurs when there is a full bladder. It can cause intraperitoneal rupture. If it is not full bladder, it may cause extraperitoneal rupture. Vascular system, that is many times rather unnoticed, maybe mesenteric vessels, maybe sometimes major branches of the aorta. They really sanguinate, but your CT or evaluation fast, whatever it is, say organs are normal. So requires a immediate intervention without any delay to save the life of the patient. So these are the different organs which are involved. So spleen is the commonest organ involved. So it's very common. Actually in Wenlock, maybe every month, in our unit at least 2-3 spleens we are removing it. In other units, suppose maybe 5 spleens even now. Even though many times there are conservative or non-operative management, the amount of injury, there are grades, are grade 3, 4, such situations. If they are hemodynamically unstable, you won't be able to salvage the spleen. You need to go ahead and do the splenectomy. Remember, it is not uncommon. We are regularly doing splenectomy in a blunt trauma. That is the commonest organ involved, and you need to think whether to save the spleen, treat conservatively, or whether you are going to go in and do the splenectomy. So this is of exactly incidence-wise. Spleen is the commonest one. Next comes the liver. Next comes the kidney. Next comes the pancreas. So hollow viscous, duodenojejunal or proximal jejunal is the commonest one. Ileocholic junction, distended cecum. When it is there, it may rupture. And retroperitoneal organs also, kidney, pancreas, urinary bladder, already told. Of course, with the pelvic injuries, they will have a fracture pelvis. So more often they will have a renal system injuries, especially ureter, bladder, and so on. So what is to be remembered again is there are two ways. Patient becomes unconscious, we concentrate on the head injury, but there is a silent, dangerous hemoperitoneum which needs immediate attention, which may be missed. Another way, patient may be having abdomen injury, thoracic injury and head injury may be missed, or fractures may be missed. So 4 systems you have to always examine, evaluate: head, chest, abdomen, fractures. This is immediately should come. Any trauma patient comes to the casualty, ask the patient name, patient is conscious, alert, probably head is okay. Then breathing, check the respiratory rate, saturation. Then something problem, then look at the respiratory system. Abdomen, look at the abdomen, tense, guarding is there, rigidity is there if patient is conscious. Then probably abdomen. Ask the patient to move the limb and check for the spine injuries also, it may be missed. So these are the 4 systems you have to always check. Injury may be masked in the unconscious patient. It's very important. You go upon thinking why it is head injury or something else. So you will forget the abdomen part and you may lose the patient. So management, initial assessment, all of you know, A, B, C, D, E. I'm not going to detail it. What is important is chin lift, jaw thrust. It's of exactly you make the patient to breathe. That is the most important thing. So other things, of course, again important thing is oxygen. If patient is getting desaturated, first thing is give oxygen, not less than 15 liters per minute. Sometimes in the casualty they give 2 liters, 3 liters. Straight away give 15 liters. There is a recommended flow, not lesser than that in an acute trauma. And after that you can titrate later one patient becomes. So 15 liters is the standard thing, not lesser than that in any trauma. This is again, there is a mistake. We tend to give less oxygen in casualty, in emergencies. And circulation, again, heart rate, BP, this is hypovolemia, hemorrhagic shock, all these features are there. IV cannula, number 14 actually, number 14 cannula, 2-bore IV cannula, immediately first place, then start fluid, normal saline or ringer lactate. Pick up the BP, make the heart rate better. Meantime, start evaluate. It's a resuscitation, assessment, further decision should go hand in hand. You take organized people, call for help, start passing cannula with the sisters, supporting people immediately, as early as possible. No time to think. Meantime, pass catheter if needed, gastric tube. It should come automatically. When you see a patient, it comes just automatically. So the things comes automatically. So that's how exactly you have to manage. And disability level, after that, of course, Glasgow coma scale, all those scales, whatever that you can utilize and say how severe is the conscious level, and exposure, and of course, then F is the passing Foley's catheter and other things. And assessment, now you got now different regions. So where is the injury? This time, once you resuscitate the patient, ask the history, either with the patient if patient is conscious, or a patient's attender or somebody brought the patient, where exactly accident, what exactly accident happened. So you can have a fair idea how severe is the injury, how much systems have involved, severity, systems. These are the two things very, very important. And examination, again, mainly whether patient is hemodynamically stable or unstable. That is very, very important. In a stable patient, all of you know that triage, primary survey, secondary survey, severity score, all those things I'm not going to detail it, you know that, or I can always read, but it comes part of it actually. And stable or unstable, this point is very, very clear. You should not have any confusion. Unstable patient should get a priority, and if you have to take a decision, whether you treat conservatively after resuscitation or whether you are going to intervene surgically. I'm not telling you intervene surgically. So what intervention, whether you do a damage control surgery or later you do a definitive surgery or definitive surgery to begin with as such, depending on the situation, depending on the organs involved, depending on the setup and backup, mainly blood. In these patients, blood and blood products, the availability is the most crucial thing. You can't replace anything else for blood loss. Only blood has to be blood, FFE, platelet. So availability of the blood makes a lot of difference to save the life of the patient. So all these things are seatbelt injury, Cullen sign, Great Turner sign, London sign is a person's name, remember, not the place name. And it says that there is some intra-abdominal injury, maybe bowel, maybe organ injury, maybe hemoperitoneum, and so on. So I'm not going to detail it, but you know that. So management strategies, quick assessment, simultaneous resuscitation, that's very, very important. Your thinking process will be multifocal. Everything you have to think, everything you have to order. You lead, you guide, you dictate, you get involved. That is the only way to save the life of the patient. No shortcomings. It's the you yourself get involved with the patient. Otherwise, you lose the patient. And quick evaluation method, decision making, whether you treat conservatively, like now all of you know that gradings are there, liver injury, spleen injury, grade 1, 2, you can treat conservatively, but proper monitoring. You should have a proper setup, good critical care unit, and availability of the blood, and monitoring the patient. Do ultrasound now, do CT scan, tomorrow repeat the ultrasound. What is the status of the hemoperitoneum? What is happening inside the abdomen? Additionally, clinically examine the patient. That is most important. Repetitive examination of the patient. That's not once you examine and keep quiet. Repetitive examine the patient every second hourly. Makes lot of difference. Your decision, which you thought initially will treat differently, will change eventually after 2 to 4 hours, because clinical pattern may change, severity may alter. Then we need to go in and do laparotomy without much delay. Of course, in the backup, keep ready for laparotomy anytime when you decide. And how quick this should be done, that's important. Those who have experience in a surgical side, we know that we organize everything together. We order everybody, we get everything, mass cannulas, catheter, everything. It takes time. But you be there, organize everything, arrange everything together. So that is the request, a lot of organization skill, lot of thinking process. Everything should go simultaneously, not one by one. That is the point which you have to remember. Monitor, manpower, organizing, leading skill. You as a consultant, you have to lead, because you don't know whether postgraduates' ability to identify the problem or juniors to ability to manage the problem. You yourself be there, take a call, direct them, and make patient all right. If there is a need for surgery, go yourself, be there and do the surgery. That is exactly. So leading skill is most important to save the life of the patient. And evaluation, I told all these things. 4-quadrant tapping we used to do when ultrasound is not available or only one machine is there, which cannot be shifted to the casualty. Now current guideline or standard is every emergency area in the casualty itself we should have ultrasound. There is a requirement NMC wise or hospital requirement or legally also. So such things are still not available in most of the setups, at least in this country. So in such a situation, what we are doing earlier is 4-quadrant tapping. Diagnostic peritoneal lavage is quite useful, but needs some sort of skill, needs some time, because you have to make an incision in the below the umbilicus. You have to pass a catheter there, fine catheter, not foolish catheter, venous catheter or any catheters. Then infuse normal saline. Then aspirate 1 liter, whatever you infuse, and analyze the content. So that is the diagnostic peritoneal lavage. And abdominal ultrasound fast, all of you know, now focus the assessment with sonography in trauma. E-fast, all of you know, is extended one. You assess thorax and pleural cavity, that's E-fast. Fast is xipiternum, right upper quadrant, left upper quadrant, suprapubic. E-fast is add-on to thorax, both sides, mid-axillary, anterior axillary, left side. So that is E-fast, extended fast. So that should be available in all hospitals in the emergency. That is the idea of requirement. Of course, CT is the final assessment. When it is available in the hospital, you can shift the patient. You can always do a CT chest, abdomen. It also gives some idea about the spine also. So you yourself should be able to read the CT. That is the most important thing in trauma. You can't wait radiologist to give the report. They'll give a report after 24 hours. There is no time for that. Basic reading of the CT picture as a consultant, as a surgical consultant, you should learn, especially abdomen and chest. And so that you can assess if there's a liver injury, what grade it is, spleen injury, what grade it is. Again, remember, most tricky situation is the diaphragmatic injury. If a diaphragm is injured, always surgery is the treatment. You never wait, you have to suture the diaphragm. Diaphragm is identified only by CT scan. Ultrasound will not be able to pick up. So CT is the ideal investigation if it is available in the hospital. But you have to see whether a patient is hemodynamically stable or unstable. Unstable patient is difficult to shift the patient to CT place. That is the drawback. So Doppler assessment of the major vessel, especially injury to IVC, major mesenteric vessels. In such a situation, good Doppler will definitely say IVC collapse, bleeding, IVC wall disruption. They'll be able to pick up. All these situations requires immediate intervention. You can't wait. Go in, use a vascular clamp, and identify which vessel is bleeding, suture it. So angiogram, in a small bleeding, or eventually if you want to do, you can do angiogram. We can also do in such a, along with that, angioembolization you can do. There's an advantage of that, but it's only in the stable patient. So this is the diagnostic peritoneal lavage. So you inject in the subumbilical area, saline you inject 1 liter, then change the position of the patient, then aspirate 1 liter, then assess the content, what are the things are there. So these are the different things. Diastolic peritoneal lavage criteria, I'm not going to detail it, how much it is, all those things are given in the book. But you assess this lavage fluid actually. So these are the different comparison of DPL, E-fast, CT scan. Ideally is CT scan, but it takes time. E-fast is quick initial assessment. DPL again needs some skill. So the different problems in that. Now treatment is identify the injuries quickly, decide for the approach, when and how quickly you are doing, that's important. And arranging, already told, auto transfusion is another thing which we regularly use it. You have to, same gauze, you can place 10-12 gauze and patient's blood. Now only thing is bowel injury should not be there. It is contaminated, you can't do. If it is organ injury, you can take the blood, filter it, add heparin, retransfuse it. We are doing it regularly, anesthetic will help. And lot of blood is replaced by patient's own, and until you get an adequate number of blood, really makes up the whatever lost blood. At least 50% makeup you can do with that. So filtering is a simple way you can do that in the regular OT as such. Central line, wall for anesthetic, critical care, everything should be organized in a very fashioned way to save the life of the patient. ABCD I'm not going to critical time window, that's very, very important. Take a decision, what you are going to do. There is no time to call somebody on your patient, your brain, your approach, your treatment. You should be very, very clear about these things, individual patient-wise. And non-operative management in a good setup, otherwise go in and do surgery. Early total care in a stable patient, we can go in, if there is a bowel injury, suture it. If there is splenic injury, remove the spleen. But if patient is really unstable, what is called as damage control surgery. All these things are the criteria. I'm not going to detail it. Hypothermia, serum lactate, coagulopathy, blood pressure, all those things. Blood transfusion near 15 units. And in such a patient, we can't do a total care, early total care, where do a definitive procedure to begin with. Open, identify the bleeder, clamp whatever it is, suture IVC, major vessels. If there is a liver injury, put a mop, 3, 4, 5 mops. Control the bleeding, and you can use a zip or loose sutures over the abdomen, put a binder, come out. Once patient is stabilized after 48 hours, go in and do a definitive procedure. So damage control surgery is definitely helpful in this patient. Of course, you start antibiotic, meantime you can arrange whatever required thing. You can take help from vascular surgeon and so on to do a definitive procedure once patient becomes stable. So many times we do that, we do repetitive procedure. We go in and do, once I opened, the patient had a celiac trunk bleeding, then put a clamp above, then put the suture, put a mop and came out after 48 hours, called vascular surgeon, then did the repair. Such things definitely happen, so you need to be, all these things are identified only after opening. What is exactly there, what exactly trauma, major injuries are there, you will identify only after opening. And of course, non-operative management, when patient is normal sensorium, remember, if there is a bowel injury, no scope for non-operative management. They'll go for peritonitis. You have to open, you have to do a definitive procedure. Jejunum means suture it, ileum may have to do a stroma. All those decisions, depending on the amount of contamination, stability of the patient, and do a stroma, ileostomy and so on. So, should be done in a proper ICU care, available surgical team, available transfusion products. Repeated assessment is important, hematocrit, electrolytes, clinical assessment, repeat fast, sometimes a repeat CT scan also after 48 hours to have an exact contrast CT you can do, to have exact injury. Again, remember, unconscious patient, you will concentrate on the head injury, you will miss major injury in the abdomen, especially vascular injury, abdomen injuries, and that will kill the patient. It is not the brain injury which kills most of the time. It is other injuries which kill the patient. That point you have to remember. So examine not only head, chest, abdomen fractures. The 4 things in emergency ward, casualty, these 4 things you should assess. That is very important. And blunt trauma in the children, again very challenging. You won't be knowing what exactly it is. There is no proper history also. Clinical assessment goes wrong, and they need rather early intervention also. Otherwise, that blood volume is rather less, maybe 2.5 to 3 liters. It is there is no time it will be sanguinated. You will lose the child unless you intervene and arrange these things as quickly as possible. Quickness comes here, real priority when you manage such patient. And laparotomy indications, frank hemaperitoneum, diagnostic peritoneum is positive, hemodynamic, unstable patient, you can't keep on trial, give blood, how much blood you can give, 10, 15, 20. Many times you have given blood, 30, 40, 50, 60 blots of blood you have given and saved the patient. So such a patient requires somewhere in the line laparotomy and control the bleeding. At the end of the day, source has to be controlled. You can't keep on pushing blood. There is no end for that. That is the point you have to remember. And repeated assessment is important. Lengthy midline incision is important. The extensions as you need. It is the life of the patient. There is no cosmetics in that. Extension right side, left side, whatever way you want. Our hands, both hands should go. Our hands, surgeon's hand, assistant's hands should go inside the abdomen easily without any resistance. That is the point. Lengthy midline incision, if required, side extension. both surgeons and assistants' hands should go inside the abdomen without any resistance. That's the point. Explore properly mesentery, bowel, organ, diaphragm. I told you need to operate. There is no conservative treatment for diaphragmatic injury. And other approaches, angioembolization, if other things are okay, liver injury, splenic injury. The splenic injury mainly when tear occurs in the hilum, they go for a pseudoaneurysm eventually. And such that the pseudoaneurysm may rupture and suddenly they may die. Once you identify that one, usually by contrast CT, angioembolization most of the time sufficient because intervention radiologists are doing good job. And if they fail, then we need to go in and do a splenectomy. Individual organ management, I'm not going to discuss. Each is different. Each has got its own grading. Clamping is different. Suturing is different. Needles are different. All those things are the technical decision making on table by the surgeons based on the experience and knowledge. And antibiotics, of course, has to be covered. Don't compromise in that. You can't have whether to give antibiotics. The life of the patient. Give best antibiotic. There is no time to think. We'll upgrade the antibiotic, all those things. Before you think we may lose the patient by septic shock. Don't allow that to happen. Hemodynamically, they're hypovolemic shock. You add sepsis in that, septic shock. Both shocks will kill the patient. At least control the septic shock. Straight away push higher antibiotic. No debate in that. It's the life of the patient between you and patient. And metabolic arrangement, again, electrolyte imbalance, acidosis, uremia occurs, acute kidney injury, liver cell dysfunction. In no time, 48 hours, the enzymes will increase drastically in this patient. Maybe due to blood transfusion, maybe due to sepsis, maybe due to hemodynamic instability. Everything is connected. Liver, kidney, lungs, brain, all these four organs are connected physiologically and metabolically. Remember, it is not the one organ injury, it's the four organ injuries always. And monitoring for complications, of course, sepsis, respiratory failure, acute kidney injury, all those things, bowel leak, compartment syndrome, everything happens in patients. Remember, we see all these complications in our day-to-day surgical life when a patient comes with the trauma. As and when it happens, our job is to identify it, respond to that, treat accordingly. If you miss these complications, you will lose the patient. There is not much time to go ahead and do something, think. There is nothing to time to think. Once you identify it, treat it. Otherwise, you lose the patient. So protocol, this is the protocol. I'm not going to detail it. It's a standard protocol CT we will do on table. Now, what is important is whether patient is unstable or not. Whether patient is stable makes a lot of difference in managing. Stable patient will be able to save. Unstable patient, we should be very quick. You should be there with the patient, beside the patient, monitor, required, intervene. That is the most crucial area. Decision is important. Whether patient is unstable or stable makes a lot of difference. So this is the protocol, of course. It is individualized, finally, individual patient, depending on that point of time, what situation, how bad patient, how exactly they present with, availability, backup, everything counts in these patients. Again, peritonitis, fast laparotomy. I'm not going to detail it, whatever I've told. This is again another protocol. So finally, organ injury, bowel injury, diaphragmatic injury, bladder injury, associated injuries, chest, brain, fractures. These are the four things, and metabolic problem. It is at the end of the day, physiological, metabolical impairment, which you have to identify, we have to correct it, you have to monitor it daily as such. So this is the bad hemoperitoneum. So we had to open and we had to do splenectomy in this patient. With the bowel injury, multiple places we have sutured. And the splenic injury again, grade 4 plus 4 injury. You can see that it's a blunt injury actually. You got a fracture rib. So the reconstructed CT image, you could see the fracture rib. This rib was abutting over the spleen and it was causing the splenic injury. And I'm just going to that. It is the surgeon's decision making, clarity, approach. This was said great surgeon Ludo Lampanchi told. Your decision making, concentration, dedication, be with the patient makes a lot of difference in managing blunt trauma, abdomen, So conclusions are, so identify blunt abdominal trauma, often it is missed. Think of associated injuries, ABCD I already told. Arrange and organize, that is also I highlighted clearly. Decision making, finally the decision making, you should be very, very clear and clarity at your approach as such. Damage control surgery or early total surgery, take a call. If unstable patient, do damage control surgery, then definitive surgery maybe after 48 hours. Most crucial is post-operative surgery. Once you do surgery, it is not over. You got a lengthy post-operative period many times. They may be in the ICU for 2 weeks, 3 weeks, 1 month, 2 months. Many times patient will be in the 3 months like that. They will be really catabolic. So nutrition is very important. Managing electrolytes is very important. Urine output getting hourly is important. Respiratory system is every system you have to concentrate and manage as and when needed. Otherwise, any time of your treatment period for 1 month or so, you may lose the patient. Patient recovered well, you are happy. After 2-3 weeks, suddenly sepsis occurs. Before you realize what happens, hypotension, cardiac arrest, death. We have seen that it's happening. Unless you monitor daily until you discharge, your concentration should be proper. You can't ignore patient. Suddenly they die. That is the most important thing. Your job is not over by doing surgery. This is very, very crucial post-operative care. Of course, shift to higher center if things are not available, especially blood. If blood is not available, put it in a good ambulance, shift to the higher center. Blood products are essential. You got only 5 liters of blood. It hardly takes much time to bleed and exsanguinate them. Unless you have got blood to replace, you will lose the patient. Availability is very important. Golden period as early as possible, as quick as possible. That is the blunt trauma. You have to be very, very clear. You have to be very, very clinically sensible. You have to very clinically assess the patient and intervene, take a decision to make them all right, to save the life of the patient. So just for the people who change after change will survive. People who change with the change will succeed. People who cause the change will lead. Like Satish is leader of us for all these things, for our medical legal aspect. So you lead, surgeon should lead. Remember, general surgeons are not just general. They are still doing very, very good job in this country. Most of the surgeons are in this country are still general surgeons. So I call them as a generals of surgery. They are not just general surgeons. They are real generals of surgery in this country. Remember, 80% of the surgical work is still done by, managed by, properly by general surgeons, remember. And this is just for undergraduates. Qualities of surgeon: lion's heart, lady's finger, horse's leg, eagle's eye, camel's bell. To become a surgeon, you should have all these things. You can start a long time. You should be very, very observant. You should have very good ladies' fingers. Ladies' fingers are very fine, unlike gents. Remember, gents have got a fine tremor. Ladies have got less tremor. It is a hormonal, actually, genetical. And so it should be very fine. And lines are very, very strong, because today you do a good job, patient is okay. Tomorrow you lose a patient. So you should have a balance between a good and bad. So morning you are happy with the good patient. Evening you lose a patient, you will be depressed. You should have very, very balanced spirit in managing the patient. Otherwise, you will really upset psychologically. So balance your spirit, actually, good, bad, accept it. Until you feel that you have done a good job, your conscience is not guilty in managing this patient, should not be worried, because half of these patients, especially trauma, you tend to lose them in spite of your day and night proper energetic effort. You should be ready for that. So balance your mind for good or bad. It's an important thing. And this is my book. I got a surgical website, free it is. Daily lectures are there. And for undergraduates, once in 2 weeks, I conduct a live lecture, case presentation for undergraduates for 1.5 hours. Whoever students, you can subscribe my this one, join live session. It will be very, very helpful. You can present also. You can communicate me, you can present. I will organize that. 1.5 hours, like any hernia, all other things. And daily 8 to 10 minutes, one lecture will be there. Always it comes. daily lectures with the 2 MCQs there in that lecture. It will be very, very helpful to learn surgery, to update surgery in a short, not in lengthy lectures, 5 to 8 minutes lectures. That is my free website. Please, you can subscribe this one. Definitely very, very helpful. Thank you very much. I am always dedicated to my college and my hospital. Thank you.